you might want to work with older adults? Maybe. Yeah. Well, and sometimes you ask. It depends on who you ask what older is. If you're 20, I guess 23 is the cutoff because at 21 you can drink. All students have told me, not here but elsewhere, that they're old at 22 or 23 because they can do everything up until that point. But when you've been through other things in life circumstances, you're like aiming for 84, 85, and etc. So it'll happen in time. Some of you, how many of you want to work in the ICU, perhaps, or the ED? You're going to see a lot of older adults come through because they're going to be, maybe they'll be on the med-surg units and they need a higher level of care. So you're going to see a 90-year-old, an 85-year-old, and a lot of systems failing. And then they can be they'll maybe go down to cardiac step down and then back to med-surg to rehab and hopefully home. So you may not directly work with older adults, but if you're in med-surg, anything non-PD or maternity, you will encounter older adults. Anybody here want to work in pediatrics? Very competitive field. Okay, that's like half the room. Very competitive field, but Ace students tend to do very well. So a lot of your final clinicals like to hire. We have a very high hiring rate from this school, especially Yale. And that we've had HR there tell us 50% of their new hires tend to come from our program because we have a limited number of people we take. We don't just keep expanding the program and making money off of people. Don't record that part. So gerontology and gerontological nursing, it's diverse, and these contributions, now I know this is a little bit technical for the first lecture, but I would know these organizations mainly because they are historical, and they really push, especially like the John A. Hartford Foundation in New York University. It's very progressive, not surprisingly, very progressive program there, and teased out geriatrics and gerontology from the other adult age ranges, middle age, young adult. And Sigma Theta Tau, a lot of you hopefully will be inducted into STTI. I know I'm a member. When I was working on my nursing 17 years ago, I had a high GPA and 3.9, but I was inducted into that, and so it's quite an honor. And when you apply for, some of you may go on for other degrees, and even if you don't, you can put this on your CV and your resume, and it just makes you look that much more accomplished. If you're not in Sigma Theta Tau, a lot of people are not, most people are not going to ask, and the vast majority are not going to care. But it's something that you do for yourselves. The American Journal of Nursing, if you are doing research projects and you have to do a paper, do you have to do a paper? Yeah. That's a good journal. Well, you can work with our librarian. Rebecca Hadreen, this is one of the journals that you'll be able to use. So you can find pretty much any topic in there. But it's one of the older journals, more established, we'll say. So I would have some idea about these. So if you see a question in HESI format, it might be something like a select all that applies, a select all, the infamous. And I joke sometimes that when I took the NCLEX, I was one of the first groups to take it on the computer. We didn't have select all that apply. And I was fortunate. I had a very high pass score on my NCLEX. I didn't know it. I felt like I failed it when I walked out of there. But I don't know if I pass it with the select all that apply. So part of the reason I'll ask you these things in tests is not to make your life miserable, but it's better that you learn it now than on the NCLEX. Yes?
So when you do select all that apply questions on our test, if we miss one, do you get partial credit or do you get full credit?
Perhaps, like on the first quiz, I think, or TWIZ, I think we'll do that so you get used to, because have any of you taken select all that apply?
Like 2 questions.
2 questions? Yeah, it's not going to be a full test by any stretch. Because usually it's like 25 questions or 20 questions, and then maybe 2 of them. I usually give 1 for every 5 to 10 questions that I ask. So this way, maybe on the first one, what I do for you guys, I will do for the traditionals, the 77 traditionals that I have. So if I give you partial credit, then I will give that to them. And then I just kind of keep making it a little bit more rigorous and difficult so that by the end, when you take your final, there's no partial credit. Okay, and then at the same time, you know, I'm not infallible. I mean, there are certain questions that might not be good questions. I try to use other resources, and Dr. Madeira has given me some. But some questions, if everybody's missing them, then I didn't communicate effectively. So with the select all that apply, you might have something that says, you know, of the following, which contributed to the history of gerontological nursing? Select all that apply. I will say this, the NCLEX may be different, but for me, always two answers. There's never, I'm not going to trick you with just one. The NCLEX might do that, I don't know, but at least two will always be correct for select all that apply. So maybe you'll see the NGNA, the American Journal of Gerontological Nursing, the American Journal of Nursing, Sigma Theta Tau. Well, you know there's no American Journal of Gerontological Nursing up there. And so that would not be a choice. As some professors like Dr. Madeira will say, what you need to do is just take each answer, potential answer, and say, is it true with the stem of the question, and move on. So formally recognized, Gero nursing was recognized in the 60s. Now again, this is before our time. Bless you. I was born in the 70s. With the clothing was, you know, from what I don't even remember, but it wasn't good. But anyway, but the 60s were a really radical time, and I give credit to the generation before mine. I'm a Gen Xer. These are the baby boomers we're talking about. They fought for a lot of civil rights, a lot of rights, and one of those was for gerontology to be recognized separately. So you see in the 70s, the 80s, 90s, and then the Y2K, the continued growth in this. So we don't have to read this from the slide, but I would understand this. So if you get a question, it's not going to be a cut and paste. I don't cut and paste the slides into an exam. You all have the advantage of having a bachelor's degree already, so you know how to think. I mean, and if you don't, you'll figure it out, but I'm sure you all do. So it's about critical thinking. What is the question asking? I'm not tricky. I don't have time for that. And it's not fair to the students. So if I'm asking about the 3 decades of growth of this specialty, that's what I'm asking about. And you want to think about that information and how it would apply. So it's not necessarily memorization. It's about applying it and saying, what is this question asking you about? So attitudes. Now, these are questions for you, but you may see this again in a form of a question. So maybe a question would be, what is ageism? And then you can look at a definition and pick the best one. Anybody have an idea, for instance, so what are some of the attitudes, bless you, towards aging and older adults in North American society? Yes?
Anything negative?
Anything negative, that's not public, yeah. Go ahead, yeah.
Like, or stereotypes.
Stereotypes. And we a lot of societies stereotype people. And that's not fair. We want to be careful that we don't make sweeping generalizations about groups of people. Now, some people might fit that stereotype, but that doesn't make it right. Most people do not fit those stereotypes, though. But you're right. We stereotype older adults and aging. We won't say about ourselves, I'm not afraid to get older. I want to get old. But how many of you know somebody who's terrified of getting older, or like approaching birthday 30 or 40 or 50 or I don't know 25? I mean, these people are afraid of that. It's like it's all downhill after 22. Well, no, it's not. And we'll learn about that in this class. Other attitudes about growing older in North American society. Yes, what is your view?
Oh, yes. That older people are the one that gets sick the most. They just usually relate older people to just being sick, grumpy,
And that's a very good point. But there are a lot of older adults who are very healthy.
right.
But we don't always, not you and me and us, those of us here, but we see the ones in the hospital or in the nursing facility. And that's only like 10, 13% And so, but we had that stereotype. I mean, how many of you know somebody who is like maybe in the 70s out there golfing? You know, they're retired and they're golfing, or they're driving an RV to Arizona or something. We don't hear about them. So maybe they're riding a Harley Davidson. I don't know, but we hear the stereotypes.
It's really hard to think that because my grandfather is 95 years old, he's like blind. He can only see at the his eyes.
He's got macular.
But he would go bowling every week, and he would get them all. Every week, that's what he does. Like every week, he get them all. So it's like 95 years old man still go bowling, still go for his walk, do a thing on his own, like not a sick, grumpy person.
Well, and so what would you say that her grandfather, what makes her grandfather different than the stereotype? What might he have learned to do? Yes, what is your name?
Lauren,
Lauren?
there's this stigma that as you get older, you become a burden on society, and that like you can't get yourself places, and you constantly need care, and you can't ambulate, and you can't like interact within a community. And Nguyen's grandfather is a perfect example of how that's not true. He goes bowling. He figured out a way to get there. He knows how to he probably is on a team or goes with other people. So.
And very good, because he also has learned how to adapt. He has his peripheral vision intact, so macular degeneration perhaps. So he's learned to adapt, and you can do that at any age. But as you grow older, you learn how to make things work, and you also perhaps in your personhood become a little bit bolder too. I'm going bowling because I want to, and I don't care what anybody thinks. And you know, it's not that he's aggressive about it, but he's not going to let something stop him. And he's had a lot of life experience to say, in the long run, it doesn't matter. He can still go bowling. So there are those things and that's changing too, with this idea of being a burden to society. And as healthcare has changed too, because you can have, and this is I'm a fun aunt, but you can have a preemie who maybe costs more to care for than an older adult. But we don't say, oh, those preemies, they are a burden to society. Now, we don't want to say that. Heaven forbid we'd ever say that. But we don't do that because of other reasons that you'll learn about in peace. But anyway, so ageism. This kind of contributes to the idea of ageism and the idea that, after a certain age and that you're considered old, and nobody wants to be branded that. It's interesting, though, my understanding of Eastern culture, growing older is something to aspire to, and it's respected. Maybe not as much now, I don't know, but I've trained in Taekwondo for about 11 years. I've been around a lot of people from the Eastern cultures. Not that everybody gets along, so don't assume that, because each country is its own entity. But being older is like what you want to be. And so it's interesting that you see people from a different culture come over here. Now nobody wants to say what their age is. I mean, as I've known some people who've come over from South Korea, they're still like 35, and it's been 11 years, and so it's, okay, whatever, so that's it, but they were not that way in South Korea. Yes.
So in Vietnam, like when I was little, I said I don't want to get old because every event, the family wedding, get anniversary for the wedding, like the oldest people, like my grandmother would sit at the front. Without the permission, the groom family would not be able to get inside the bride's house, or without that permission, no ceremony, no anniversary would be started. So we're like, I want to get older and all this power.
Well, and they carry the power and the history and the legacy. Yeah. I mean, how much of a legacy do you have when you're 3 years old?
Right.
How many, it's like maybe you have some. I don't want to stereotype, but there's something, I appreciate your sharing that, because my understanding of the Eastern cultures is being older. They don't study gerontology over there. It's just, it's not an issue. We have to make it an issue in Western society. So some definitions, you will be tested on this. The gerontology versus geriatrics. In the next slide, we'll see that. So gerontology, that's that broader term, the study of ology. and this aging process, and you know the words that we don't necessarily want to say. But what is old? Who defines old age? We don't have to answer that right now because we have about 20 minutes left in the class. But I would know these guidelines. These still sort of apply. It used to be even younger. Next year with a different book, I'd like to see this have changed. You know, it used to be people retired at 65. Anybody know anybody who retired at 65 or maybe 62, depending on like their Social Security? Well, I don't get to retire until I'm 71, which is fine because I want to work. I would like to get to be 71 and enjoy retirement. I mean, I love my life. Don't get me wrong. Don't put that on there. I love my job. Okay, so, but the 60s are really, really good years, and so are the 70s. I mean, the 80s and the 90s can be too. But it used to be thought, well, at 55 or 60, you're kind of going downhill. But people learned how to take care of themselves better. We had advances in healthcare, all these other things. And not just healthcare, but economic types of things too. So all kinds of things happen. But I would use these guidelines because, you know, in healthcare and many fields, we like to characterize everything. So we've got the young old, the middle old, and the old old. And I'm not sure that those are the terms I would use, but those are what your book uses. So as you look through that first chapter, kind of have an idea. It's not like a question will say, which of the following is considered the young old? It may not be written that way, but it will give you an idea. You think, okay, well, if this person is 74 years old, then that person would be, according to our textbook, a member of the young old, that kind of thing. So, again, I'm not tricky. I think, you know, ACE students seem to, you know, relatively, again, no pun intended, ace the exams. But you guys you'll get it. And then geriatrics. So gerontology, nursing doesn't necessarily say geriatric. I mean, we are now, history, medicine has started to share some of its terminology. We used to not be able to say as nurses, you know, asthma. Instead we have to say alteration in respiratory status. And in our care plans we do that. And in our nursing diagnoses we do. But geriatrics, this is specifically refers to medical care. So sometimes people say geri-clinical. That's fine, but technically we're nursing, we say gero-clinical. So it's a minor detail, but geriatrics tends to be a medical specialty, whereas gerontological nursing or gero-nursing, and you can say geriatric nursing, you know, more or less, but technically the two are different. And then, so gerontological nursing, we borrowed that from the field known as gerontology, which kind of came into its own in the 60s as well. So the role of the gero nurse, and we got a couple minutes here. So these are some that your book lists. I mean, how many of you right now are worried about becoming policymakers? Maybe not right this instant, right? So, how many of you plan to, after you graduate, you pass your NCLEX, become direct care providers? You know, working in a nursing facility or a hospital or something. I mean, that's usually a lot of people's first step is becoming a bedside, working at the bedside. And that's sort of, many of us think this is not the way you have to go, but a lot of generations of nurses think that's, you know, where you earn your stripes. And that's where you get to apply what you've learned and build up expertise. Because I've had students, former students from other universities where I was teaching while I was doing my doctorate, write to me and say, well, you know, I just got my RN, I want to go on for this type of program. That's fine. I'm not somebody who says you have to have 10 years of experience before you become whatever. I'll write a letter. But then I had a student recently, she told me that she was rejected from a DNP program in another state. And she was very distraught. She's very bright. And I wrote her a strong letter of recommendation, but she said they seemed to think she needed more experience. So she's trying, and in my conversation with her, a former student from another university, it was just, there's no shame in working as an RN at the bedside. This is not, you all can define for yourselves who you are. but don't ever feel like being a nurse at the bedside is a bad thing. When I did teach clinical, and again, hopefully next year I'll be able to teach it, I used to tell my students that I would fail them for two reasons. One of which is if they killed somebody, they'd have other consequences to pay for that, or if they said I'm just a nurse. So if a physician or in physician, medicine has changed somewhat, but if somebody else came and said, oh, who are you? And you said, well, I'm just a nurse. You fail, and because you're not just a nurse. We don't hear other professions saying, well, I'm just a, and if they are saying that, they should not. We are nurses, and you guys are going to be specifically RNs, a registered nurse. I mean, that's a big deal, and that title carries with it a lot of respect and a lot of responsibility. So in time, you may become instructors of some sort. If you get your master's, your MSN, I know I did a lot of clinical instructing over the course of my time at UConn when I was doing my PhD, because I had an MSN, and I had a number of years of experience as an RN. Because if you're going to teach other people, you kind of need to know what you're doing. And some of the technology in the Pyxis system and Epic or this or whatever, that changes, but it's kind of all the same. We get a different type of pump. It used to be, had a Baxter pump. You guys probably don't even know what that is. I used to want to throw those things out the window. Then you get the Alaris and the Plum pump and all these other things. But once you know one, you kind of can figure it out. Advocating. We don't have to go through each one of these, but this idea of, well, has anybody in here ever worked in like human rights capacities or like, I don't know, done a peaceful protest or chained yourself to a tree or, something where you were standing up for a cause? Anybody ever done anything like that? Okay. All right.
I do volunteer work with animals.
Okay, so there we go. And remind me of your name?
Damien?
So you're passionate about animals' rights because somebody's not able to, they can't speak for themselves.
Right.
So you as RNs will be advocating for people oftentimes who cannot speak for themselves. If you're working in the ICU or you're working with kids, a lot of times in the ICU people are intubated. Not always, but they can't talk. They're in a drug-induced coma. So you need to be able to advocate for them. And the same with children. Maybe if you suspect abuse, you need to be able to advocate, talk with social workers and whatnot for that child who might be afraid to report that his or her parent is hitting him or her, or maybe starving him or something. And then leaders, I mean, to me, RN and leader kind of go together, but you'll find that out as you go through your nursing career. And then evidence-based clinician, this whole idea of evidence-based, years ago, it used to be, and this was before any of our time and those of the people who are teaching you in other classes too, people did things because that's how it was always done. Anybody ever hear of that, like in any profession, or just that's how we've always done it, we're not going to change it? We don't have to change everything. Some things are good the way they are. But other things, we want to have evidence. Why are you doing this? So why are we using, take something simple, why are we using the same book that we used for the last that Dr. Ercolano and I used for the last 3 years? Well, it's still accurate. And basically it's accurate. And why, it doesn't need to be changed. Plus you guys can buy it at a less expensive cost. But there may be a time, i.e. next year, when we need to switch over to something else. And preferably an ebook version so people can, get a discount on that, and et cetera. So all of that to say, an overview today. Next week there'll be, we don't have class on Monday. On the 12th, there'll be some more information, and then the 19th, and then you'll have your first quiz on the 26th. And nobody has to answer this, but I have a brother who loves baseball, and this was brought to my attention about, how old would you be if you did not know how old you are? And I think I would forever be, 35. The 20s, oh, no, you can't, no offense to anybody in your 20s, but I would not want to go back to my 20s. 30 was when it started getting good. So let's just, as somebody brought up with the stereotypes and all these things, as you go into your clinical setting, keep an open mind about people. Some people who are gonna be 80 will need a lot of care. Some people who are 80 will be bowling. So, that kind of thing. All right, so let me know if you have questions. You can email me, and otherwise, I'll send you the slides. I'll post them now that you can see Blackboard. I'll post them hopefully by the end of this week for 2 Mondays from now. Okay? So it's good to meet everybody.